Well, hello everybody, and welcome to our first IPALA Leadership Conference. It's such a pleasure to welcome you here today. My name is Vicky Timmis. I'm a paediatrician from Sheffield in the UK, and I'll be helping lead us through the session today, along with Alicia Mitchell, who's a paediatrician from Australia. So welcome to our first conference. We've got 3 days of really exciting and inspirational speakers coming to speak to us from around the world with a wealth of leadership experience. So we can't wait to get started and hope we're all going to learn a lot. Should we go to the next slide, Alicia? So this conference is hosted to you by IPALA. We are the International Pediatric Academic Leadership Association, and if you scan this QR code, you should go to our website where we have kind of a wealth of educational opportunities going on, and you can sign up. And also we have links to the next couple of days of the conference. So there will also be talks going on Wednesday of this week and also then Friday at the same time as now. So do please scan the QR code and see what else IPALA can offer you for learning and leadership experience. So just going over the conference over this week. So we have 3 days. As I mentioned, they will all be at this time frame. So today we're going to talk about the theme of advocacy in our second session. On Wednesday, we'll talk about managing ourselves and managing others and how we can work well in teams. And then the third day is to try and inspire us and think about how we can reimagine our leadership within our different workplaces. So just going over the itinerary for today a little more. So we're going to have our first session, and we have Dr. Camilla Kingdon from the UK coming to speak to us, followed by a second session by Dr. Angela McGower. And at the end of that session, we'll have some question times. So and then we will have a break, followed by our second session on the theme of advocacy. Then we have Professor Margie Danshin and also Dr. Maria del Carmen Kai coming to speak to us, followed by a second question time. So just to go over a little bit about this platform for those of us that haven't used it before, as attendees, you can't put on your camera or your microphone. That's just for those that are speaking. But we do have a question function, so you should be able to see at the right hand side at the top of your screen there is a speech box with a question mark inside it, so you can click on that and write in any questions. We will then go through those at the end of the sessions at the question time, and we'll ask as many as we can as the time allows, so please do use that. Just to note that we are going to record that. This is just the nature of it being a global conference and the different time zones that we're working in, so to enable people to access this whenever they can at their own time. So without further ado, it's very exciting. Let's get started. So let me welcome you, Dr. Camilla Kingdon. Dr. Kingdon is a neonatologist from Evelina Children's Hospital in London in the UK and is our immediate past president of the Royal College of Pediatrics and Child Health. Welcome, Dr. Kingdon.
Thank you, Vicky, very much indeed. I feel incredibly privileged to be here and to have the first slot in this really, really interesting leadership webinar series that you guys have put together. So a real privilege to be here. And I want to particularly thank Professor Kevin Forsyth, who has been championing this topic for years. And it's wonderful to see it all coming together in an event like this. But it's massive credit to Kevin for beavering away at this and flagging it up as a key issue, and particularly thinking about diversity in healthcare leadership, which is what I'm going to particularly focus on this morning. So thank you for having me. Alicia is very kindly going to do my slides. So next slide for me, please. So I thought I would use my 20-minute slot to lay out, to begin with, why I think we are at such a crucial time and why I believe, need a new leadership paradigm. The current state of healthcare needs globally are absolutely immense. And we are also in a very strange year, 2024, with huge amounts of churn politically. I think 64 different countries are holding elections this year. In fact, it's probably 65 now because France have just decided to hold a general election. So 65 different countries holding elections. But this gives us a really, really important opportunity for thinking about how we make child health a priority, and how we are posing the questions around children's health to the leaders as they enter elections, and how we develop our own leadership so that we're able to navigate our way through what is a very complex and challenging healthcare environment. And so in the second part of my talk, I'm going to propose a model of leadership that I believe will help us rise to these incredible challenges, and help us face the very complex healthcare systems in which we work. So next slide, please. Thank you. So since the pandemic, we have seen huge pressure and demands on healthcare that have risen in every possible way. We know that the cost of healthcare has risen enormously. We also know that there's an incredible shortage of doctors and nurses globally. In fact, by 2030, there's a prediction that we'll be 26 million people short, particularly nurses and midwives, but also doctors. And we also know that the pressure that our healthcare workers are under is immense, with high rates of burnout being reported across the world and real problems with retention of doctors and nurses and midwives. And we also know that many countries are facing industrial action from healthcare workers. Certainly here in the UK, we've had our nurses go on strike, we've continued to have our junior doctors go on strike, and so on. And I think what this is telling us is that the system is under immense pressure. But at the same time as we're facing these enormous workforce issues, we're also seeing that we have rising needs amongst the population, rising numbers of people, but also rising numbers of people needing healthcare. And we are seeing a significant impact from these social determinants of health that are really making this more and more of a priority. Climate change particularly springs to mind, but of course there are all sorts of other social determinants of health that are really focusing this as a key issue. And health inequity is worsening dramatically. And we are seeing that people from minoritized ethnic groups all over the world are facing real problems in accessing healthcare. And we know that particularly children tend to fall particularly into this group and are particularly vulnerable. Next slide. So if you can just click it again. Oh, no, sorry. If you go back to the previous slide, something's happened to that slide, but we'll just have to live with that. Sorry, Alicia, I don't know, half the slide hasn't come through. So healthcare, what I wanted to say in this slide was this idea that healthcare leaders are facing incredible difficulties and in priority setting. Because on the one hand, we know that we know in this country, for instance, huge concerns around elective waiting lists. And I know this is a problem around the world. We know, for instance, that children can wait 2 to 3 years to be assessed if there's concern that they may have autism. We also know that there are peaks and troughs in the pressure that the system is under, and certainly in the Northern Hemisphere, and I know it's true actually all around the world, is that winter, for instance, brings particular pressure on all our systems, where we see huge increases in demand through our emergency departments. We see problems with patient flow. Our critical care capacity is often exceeded, and that then means we have to start cancelling elective surgery. And so we see this kind of spiral of pressure that happens in fairly predictable times throughout the year. And so this pressure that the system is under means that there's real competition for resources. And so we find that, for instance, children's healthcare will be competing with adult cancer targets or adult elective surgical recovery. And so our healthcare leaders are faced with extraordinary challenges in balancing all these competing healthcare needs. And so I think it's not really surprising then that the leaders within healthcare systems are struggling, therefore, to prioritize the importance of joy in work, of paying proper attention to the emotional needs of staff, of really thinking about staff retention and staff burnout. I think it's also a reason why I don't think our healthcare leaders are focusing anywhere near robustly enough on addressing health inequalities and what our hospitals and our health systems' responsibilities are around addressing those. And I think also the green agenda and the whole agenda around sustainability, where we know healthcare systems have got a huge responsibility to act, has slipped down the list of priorities because the people in leadership roles are simply unable to prioritize it. And so I think we are living in very, very challenging times. And so the test of true leadership is now being applied in a way that perhaps we've never seen it before. But it's exactly at times like this when we need our healthcare leaders to be able to step up and lead. And I don't think we can allow our leaders or any of us that are in leadership roles to step away from our responsibilities to not only focus on the pressures that the system is under in terms of targets and waiting lists, but also pay attention to all these other responsibilities. Particularly thinking about, burnout, morale, the wider determinants of health. And so I think the longer we delay thinking about how we face all these competing problems, in fact, the worse the situation is becoming. So Professor Don Berwick, who's quoted on this slide, has put it beautifully, where he says that it's not a smart investment for society to keep running healthcare as a repair shop. And I think if most of us reflect on the systems in which we work, it's often very, very like a repair shop. We bring people in, we bandage them up, we send them back out again, but we're not getting at the kind of core reasons why people are becoming unwell. And so he says we must move upstream to the real generators of illness, injury, injustice, and disability. And he says very poignantly, and I think for those of us working in the child health arena, this for me really strikes a chord, that each of us has only one life, but our children have only one future. And so we cannot allow healthcare leaders off the hook. We have to, any of us in leadership roles, and I would say probably everyone on this call is in a leadership role, whether you're leading a team, a department, a huge health system. We have to be able to address these wider determinants of health, just at the same time as we're addressing the problems within our system right in front of us. So there's a real challenge here. And now clearly, we need financial investment, but money alone is not going to address these issues. We need real innovation and transformation. We need people to be able to think creatively and have the headspace to really reimagine their services so that they really can start moving upstream to these real generators of disease. And we need our children's healthcare professionals to step up and show leadership in these very, very challenging times, where it's such an important moment globally. A moment where we need to be able to pivot. And the only way we can do that is if we allow absolutely everyone to step up and play their part. And so I think there's never, ever been a more important time where we need to be able to allow all voices to be heard, for everyone who wants to play a role to come to the table, and why we need diversity in leadership more than we've ever needed previously. So my next slide. So the truth is that women are globally shamefully underrepresented in leadership roles. And I'm going to talk about diversity in its greatest sense, but I just want to focus on women for the next few minutes. As I've said, we're at such a key moment where the need is so enormous. And so we can't afford to have a situation where huge numbers of very able people are not able to have their voices heard and move into leadership positions. And I think there's now a general recognition that there is a massive underrepresentation of women in health and social care leadership positions. And the document that I've got here on the left-hand part of this slide is a publication from the World Health Organization. It's called Delivered by Women, Led by Men. And the truth is that globally, health and social care is delivered hugely by women. So 75% of healthcare is delivered by women. But actually, when you drill down into the proportion of women in leadership positions, actually only 25% of leadership roles in health and social care are women. And this is despite the fact that we've now had several decades of parity of entry into medical schools for men and women. And so it's not like we don't have enough women graduating from medical school. And if we're thinking more widely, we know that in the nursing and midwifery workforce, we've got huge numbers of women. So there is not a shortage of women in healthcare, but what there is a shortage of is in women taking leadership roles. And the reason why this is so critical is because we've got this eye-watering shortage of health and social care staff globally. And so if we're really ambitious about achieving the targets laid down by the Sustainable Development Goals, which after all are things like good health for all, gender equality, and so on, we really, really need to enable more women to take on leadership roles so that we can really start addressing these huge shortages in the workforce globally. But I think we can only do this if we have leadership that is both inclusive and compassionate. And so I think there's a signal that's telling us that women are not choosing to take on leadership roles, and we need to try and understand why that is. And I would argue that we need a much more compassionate, inclusive leadership paradigm, because that enables staff to innovate. It promotes psychological safety so that people are enabled to speak up and to question. It promotes an environment where people are comfortable to take risks. And that's what we need at the moment because the demands are so enormous that we're all facing. Next slide. So I'm very compelled by what is known as compassionate leadership. And there's now a huge evidence base. So for any of you who are particularly kind of geeky like me and want to read up a lot about this, there are numerous books written on the topic. And I personally would particularly recommend Professor Michael West, who has written extensively about compassionate leadership in the healthcare environment. And so I think we've got a situation now where we need to rethink. We need to move away from the kind of old-fashioned command and control style of leadership. And we really need to think about a style of leadership which is underpinned by kindness, so that it can focus on really thinking about the culture of work, thinking about morale, thinking about retention. And the whole topic of intelligent kindness, of course, is a lecture in its own right. And I hope you're all aware of the huge evidence base for kindness in healthcare. It's now extensive and is showing significant improvements in patient outcome and staff retention. But I think what we really need is that in order to deliver kind healthcare, is that we need compassionate leaders. So next slide. Thank you. So for me personally, I think the tipping point came on my leadership journey when I looked at some of the data, and this is UK data, so I apologize for that because this might not be relevant to all of you, but I guess I just wanted to explain to you where I'm coming from. so I'm, originally South African, but I've done all my pediatric training and been a consultant here for many years, and very proud of what we've achieved in the United Kingdom. But this data really, really bothers me. So on the left-hand side of this slide is the infant mortality rate for the United Kingdom. And you won't be able to see the detail, but these are a list of OECD countries. And you'll see the United Kingdom, which is the pale blue line, right down third from the bottom. I looked at this slide and I can't believe that the system in which I have given so much of my life to working in, and that our infant mortality rate is right down there, right down at the bottom of the pack. So what is going on? And then even more worrying was last year, our wonderful National Child Mortality Database, which is this incredible resource that focuses in huge detail on every single child that dies in England and produces incredibly rich data. And what the slide on the right is showing you is that our child death rates are going up. So in England, child death is rising. And so I looked at all of this and I thought, there's something really badly wrong here. How can it be that the sixth richest nation on the planet has got these sort of child health outcomes? And actually, if you look at obesity, mental health, vaccination rates, the graphs all look the same. And essentially, the underlying reason for all of this is poverty. And so it comes back to these wider social determinants of health. And so the reason I'm showing you this slide is that I think for each of us, we've got some very, very compelling issues to deal with. And for me, this was a real turning point. It made me realize that we've got to do something radically different because things are not looking good for children. Next slide. So just to kind of pull it together and make this a bit more international, I think wherever you look, and I'm sure for all of you this is ringing true, that we've seen a slowdown in the improvements in infant survival after some really incredible improvements globally. We're seeing rising mental health problems all around the world, rising non-communicable diseases, and I'm thinking particularly of obesity here, but there'll be many others as well. And of course, really worrying trends around climate change, which, as we all know, disproportionately affects women and children. So the challenges that we are facing are absolutely enormous. And I think it's quite easy to look at all of this and look at those graphs that I showed you just now, and you just sit there and you feel unbelievably depressed because you think, what on earth can we do to turn this around? But the truth is, and I realized this in my 3 years as president of the Royal College of Pediatrics and Child Health, is that actually I don't need to fix these problems as an individual. But what I do need to do is convene and pull together the numerous brilliant people around me, many of whom have got some really smart ideas. So my role as a leader is to set up collaborations, it's to convene discussions, it's to enable these brilliant people to come together to brainstorm. And for me, that was a really important leadership lesson. I don't need to be an expert, but what I do need to do as a leader is identify the experts around me and enable them to have their voices heard. And so I found that really empowering. I felt quite liberated. I suddenly thought, I don't need to fix these problems, but I know lots of people who have got some clever ideas, and I just need to build them, bring them together. I need to encourage them. I need to galvanize them. And so for me, that was a really, really powerful leadership lesson. Next slide. So I just want to, because I'm conscious of time, just give you 5 bullet points around, and this is Michael West's work. So if you're interested to read this in more detail, he's developed a 5-point leadership strategy for those of us that work in these complex healthcare environments, which I would suggest we all do now, where you're needing to work across boundaries, where you're not just sitting in a hospital or sitting in a general practice, but where you're having to interact across systems, working between health and social care. For those of us in child health, we're often having to work with people in education settings, we're having to work with charities, and so on. And so he starts by saying you need to develop that shared vision, because everybody needs to galvanize behind that kind of that purpose, that true north. What is our true north? Where are we all heading? And that then enables you to sort of help people stay on track because you've developed that kind of vision. And And because doubtless there'll be some bumps along the way, but if you've developed your shared vision, you can kind of keep going back to it and keep people on track. And then you need to commit to collaborate, because there are going to be times when there's differences of opinion and people are annoyed or tired. But if you've committed to collaborate, then you start developing those long-term relationships. And you do that by frequent positive personal contact. And I'm afraid Teams and Zoom and these online environments are only good up to a point. You actually really do need to have, like, let's get together for a cup of coffee. When are you next in town? I'll make some time for you. We need to kind of sit down around a table. So I think personal contact is immensely important. And compassionate conflict management. When you're under pressure and you're dealing with difficult problems, you are going to have differences of opinion. People are going to get annoyed with each other. So you've got to learn to develop strategies that say, actually, we value difference of opinion, because often that's when the best innovation comes. But we've also got to deal with it maturely and compassionately. And then finally, altruism. That means leaders saying, I commit to this. I commit to working altruistically. And I think that's incredibly important. And Alicia, if you give me the next slide, because I'm an unashamed fan of Brené Brown. And this next slide, it hasn't come through. It's a slide. Brené Brown says, I am here to get it right, not to be right. And I think that's so powerful, because it's all about saying, not about me saying, how can I win? It's about me saying, how can we collectively succeed to crack this problem? So just to finish off, I want to challenge those of us that are in leadership positions, because I bet you that I've got, there are 120 people at this webinar. I bet many of you are in leadership positions, and you're probably thinking, but how can I do this? Two things: intentionality and accountability. So the road to hell is paved by good intentions. So we've all had good intentions, and we've seen many of them come to naught. So intentionality is absolutely crucial. And there are way too many kind of sloppy, poorly thought through programs of work. And I've certainly seen this, particularly around the diversity and inclusion agenda, where people have got they've got the best intentions, but they haven't thought through how to do it in a really intentional kind of way. And so I think being really intentional about wanting to create diversity in healthcare leadership, about really wanting to be inclusive and bringing everyone to the table, about investing time in it, about saying psychological safety is key, because I want to create an environment where I'm happy to be challenged. I'm happy to be wrong, but I want to hear all the voices. So being really intentional about it. And then accountability. And that needs courage. During my time as Royal College President, there were some very bumpy moments. There were times when I got it wrong. And I had to say, I'm really sorry. I was wrong. And I think that takes a lot of courage. And I'm not saying it's easy. I certainly didn't find it easy. But I think unless as leaders we're happy to be accountable, we're not going to create the kind of environments that are really going to be able to transform and innovate. Next slide. Actually, I think this is my Brené Brown slide. I got confused. Yes, it's my Brené Brown slide. So this is something that I endlessly remind myself about. I'm here to get it right, not to be right. So it's about leaving my ego at the door and saying, I'm not an expert. Let's collectively try and get whatever this task is right. And I think that's such an important message. And it's something that I try and hold really close to my heart. And then my last slide. So for those of you that haven't come across the Man in the Arena speech that Teddy Roosevelt gave back in 1910, I find this incredibly powerful, because I'm not pretending any of this is easy. And so this quote is so important to me. It is not the critic who counts. The credit belongs to the man or woman who is actually in the arena, whose face is marred by dust and sweat and blood, who strives valiantly, who errs, who comes short again and again, and who at worst, if he or she fails, at least fails while daring greatly. So my greatest message to you all is dare greatly, be brave, be prepared to get it wrong. But at the end of the day, dare greatly, and I wish you the very, very best. Thank you very much.
Wonderful talk, Camilla. Thank you so much for those insights on leadership and for sharing your experiences that you've had with us. That was so insightful. And I think you can see by all of the reactions on the side of the screen just how many people really appreciate your words. So thank you again for that. I hope you can stick around until question time at the end of the session. And hopefully we'll have some great questions from some of our participants to ask you at that time. So thank you very much.
Thank you.
I now will introduce our second speaker for today. That is Dr. Angela McGower. So Dr. McGower will be speaking to us also about the theme of leadership. She is a pediatrician from Kenya. She has a master's degree in pediatrics and child health from Aga Khan University Hospital and a bachelor's in medicine from the University of Nairobi. She has studied her PhD at the University of Ghent in Belgium and has completed a fellowship of pediatric rheumatology at McGill University in Montreal. She is a consultant in general pediatrics and pediatric rheumatology and is an assistant professor at the Aga Khan University Hospital in Nairobi. She is also the president of the Pediatric Society of the African League Against Rheumatism, and she was the national vice chair for the Kenyan Pediatrics Association until earlier this year. I would love to let her take you away on some really insightful leadership points that she can share from her experience. So Angela, the floor is yours.
Thank you, Alicia, for that very warm welcome. I hope you can hear me clearly.
We can.
Okay, great. I'd like to say thank you to Professor Kevin Forsyth and Professor Bob Armstrong, who've made it possible for me to be part of this wonderful global initiative. And thank you, Professor Camilla, for really setting the stage for this leadership conference. So the title of my talk is really to share with you some of the strategies we have used to advocate for childhood rheumatic diseases in Africa. Next slide. I'd like to share with you a bit about Hope Arthritis Foundation, of which I'm the founder and CEO, where we are hoping to improve quality healthcare outcomes with a mission to accelerate positive outcomes for children with rheumatic diseases. It's a non-governmental organization, and we envision a world where every child with rheumatic diseases thrives, and we hope to empower patients, guardians, health workers, and health institutions. So you can follow our social media accounts to see what we offer and visit our website too. Next slide. So the objective of this talk is really to share the life lessons learned in my advocacy journey for childhood rheumatic diseases in Africa. Next slide. And I'll begin with a case, and we'll name this young girl Halima. She came from a distant border town between my country and Somalia. And for about 2-3 years, she developed this right knee swelling, which progressed on to lead her knee to be in a fixed flexed position, so she was unable to walk. And in her visits in the nearby hospitals and facilities, the solution that she was being offered was amputation of her right leg. But her father was convinced that there was another option. And so it took him 2-3 days to travel to one of our mission hospitals closer to our capital. And when they arrived at Mission Hospital, they weren't sure of the diagnosis, but they knew this is likely something rheumatological. So she ended up in our pediatric rheumatology service. And the good news is we were able to treat her. She was able to have correction of her knee without going through the tragedy of being amputated. And it is cases like this that have inspired us. So we'll begin with a quote by Chinua Achebe, who said, "Even the village rainmaker no longer claimed to be able to intervene. He could not stop the rain now, just as he would not attempt to start it in the heart of the dry season without serious danger to his own health." And for me, this quote makes me embrace the concept of the seasons of life. And it's the first lesson I'd like to highlight is understand your context and the environment where you are actually operating. Next slide. And why is this important? Because we know in sub-Saharan Africa, we are suffering from the double burden of communicable and non-communicable diseases. And the communicable diseases have grabbed the lion's share of attention because of the risk of mortality. But as Professor Camilla already highlighted in her previous talk, the non-communicable diseases are not waiting for us to win the victory over communicable diseases. So it's important to come up with strategies for both entities. And this is happening in the backdrop of our countries that are rich in resources, rising economies, but still we do face significant socioeconomic challenges. Next slide. The next quote that I'd like to highlight is by Malcolm Gladwell. And he said that we overlook just how large a role we all play, and by we, I mean society, in determining who makes it and who doesn't. So we are all part of a puzzle, and how we synchronize does impact. So the second lesson I'd like to highlight is even as you're cognizant of your context, acknowledge your foundations and define your destination. Next slide. So for me, one of my key foundations is my family. And I'm showing there the picture of my mom and dad, because even to this date, they still form part of the foundation of the values of which I have. So I challenge all of you to reflect deep within and interrogate what are the values that steer you, that propel you forward, even as you navigate various aspects of life and various advocacy agendas that you would like to pursue. Next slide. Another very key foundation for me was actually the center of my first employment as a doctor. And this is a mission hospital at the foot of Mount Kenya. It's about 4-hour drive from our capital. And I think for me, in this facility is where I really learned some of the key concepts that Professor Camilla was talking about, compassion in healthcare, because our supervisor was a phenomenal human being, a surgeon, but was always ready to advise and assist. Another key impact for me here is that despite it being a primarily clinical center, when I came up with my first research idea, I received overwhelming support to be able to carry it out. And that is how my career in research actually began, in a distant hospital at the foot of Mount Kenya. Another key foundation pillar from this hospital is that they are the ones who sent me for my first ever rheumatology conference. And at the point I was really not interested. I didn't understand why. But now I can see that that exposure led me to develop interest in pediatric rheumatology. Next slide. And at that conference that my first employer hospital sent me to, I was able to meet these phenomenal people who I have shown here. Because at that conference, they had developed something called the International League Against Rheumatism East Africa Initiative. And the goal was to actually increase the workforce available to care for people and children with rheumatic diseases. The black and white picture is Professor Ines Colmena, who at the time was studying adult rheumatology, and she connected me to the ladies at the center, Rosie and Carol Hitchen, who were able to assist me in getting a scholarship to be able to pursue my pediatric rheumatology fellowship. And at the extreme right is Michelle Meltzer, who has started an NGO which is now looking to support pediatric rheumatology trainings in Africa. And the gentleman at the bottom, Professor Mondi Oyo, Professor Girish Modi, and Robert Moot, these are gentlemen who have been phenomenal in availing virtual educational programs to spur the interest of rheumatology. So you can see there have been many people who have been involved in my journey in pursuit of pediatric rheumatology, and I'm eternally grateful. And so once I was able to get my training, I think one of the challenges posed to me by my mentors then was to be able to drive change and transformation for these children. And so the next thing I'll be talking about is how I was able to establish this service. Next slide. One of my favorite books, Atomic Habits, mentioned this really powerful quote that habits are like the atoms of our lives. Each one is a fundamental unit that contributes to your overall improvement. Sometimes we have this big picture of what we want to do, but I'm a strong believer in small beginnings. Because when you do start small and you keep learning, then you have the opportunity to learn from your mistakes and improve as the days go by. And so the third lesson I want to share with you is define your modus operandi. Define how you want to conduct your advocacy agenda and be ready to learn from the mistakes that you make. Next slide. Next slide. So the first thing that I was able to establish after I finished my fellowship and being hired once again at the Kakan University Hospital was actually establishing the pediatric rheumatology clinic, because I knew it was going to be important to prove to people that these cases exist and develop a database to show people that there is room to improve the lives of these children. And with the support, of course, of the social media team and the marketing team, we're able to get the word out there about our clinic. I really believe in data, and so one of the things that we're able to do was to establish our own in-house database. And from this database, I'm really proud to say that some of our trainees, some of whom are logged on here today, have been able to tap onto this and generate several abstract publications showcasing the world that we do have pediatric rheumatology cases amidst us. Next slide. We cannot forget the importance of the people we are serving. And you know, the issue of patient-centered care, appreciating the voice of the patient is very key. So some of the things we've been able to do is have an open awareness days for various entities. And this is just an example of where we're able to bring patients together for them to voice out their concerns as we advocate for their diseases with various stakeholders. Next slide. Information is the oil of the 21st century, and analytics is the combustion engine. If we're going to be pediatric and child health leaders relevant in the 21st century, we cannot shy away from pursuing and generating data to drive policy, change, and transformation. That brings me to my fourth lesson. And as Professor Camilla said, you cannot do this alone, right? But identifying people who share in your vision and your mission and working together, that is the way forward. So my fourth lesson is establish the coalition of the willing along your destination path. Next slide. And as I said, you can't do this alone. So one of the first publications that we did was together with some of my mentors and even colleagues in the pediatric fraternity, where we were able to showcase that we did have pediatric rheumatology patients being admitted in our facilities. And some of the common conditions we were seeing, for example, were arthritis and infection, among others. Next slide. And we're able to show this not only in our inpatient facilities, but also in our outpatient facilities. And again, some of the commonest conditions we were seeing are arthropathies where joints are affected, infections were also not left behind. And as we strive to get solutions to the challenges we face, as I said, it's important to honor the voice of the people we are serving. So we did a qualitative inquiry to really understand the challenges that health workers were facing in Kenya when they encountered children with arthritis and associated diseases. And what we found is that most of them feel confused, sometimes even fearful, because they feel helpless, not knowing what is the intervention that they can offer these children. And this is compounded by the interplay of lack of knowledge and health systems that they felt were not supporting them in diagnosis and management. Next slide. Next slide. Let's go back to the previous slide. So the same cohorts, after hearing their challenges, we then inquired with them what are some of the solutions that they feel we should be able to offer to help them overcome the challenges they face when they encounter children with arthritis and associated conditions. Next slide. And here they were able to actually tell us about a three-pronged strategy where it's important for us to come up with solutions for the patient and the community, primarily centered around raising awareness, and then for the health workers to avail education and algorithms that they can easily follow in diagnosis and management, and ultimately the health ecosystem to ensure that the diagnostics and treatments are affordable, feasible, and sustainable. Next slide. And again, in the spirit of the Coalition of the Willing, during the COVID pandemic, we were able to come together with colleagues across the Republic of Kenya, showcasing one of the most severe complications we witnessed in children during the COVID season. And in a span of 1 year, we were able to identify 20 cases. Fortunately, only 4 of them really needed ICU admission, but the follow-up really wasn't very well done because of lack of resources. And some of the challenges we faced in this study, because we're doing retrospective data, was reviewing retrospective data. Of course, there's often the challenge of missing data, but nonetheless, we're able to share what our findings and outcomes were for our cohort. And the investigators here included nutritionists, nurses, and healthcare and doctors too. Next slide. Next slide. Okay, that was just showing some of the various laboratory features. Okay, I think we've already talked about this, establishing the Coalition of the Willing. Let's proceed on to the next slide. And I've talked a lot now so far about work in Kenya, and now we are going to spread our wings into the work we have done across Africa. And it has been a real honor and humbling experience to be among one of the founders of the Pediatric Society of the African League Against Traumatism, where we are aiming to advocate for our children in Africa who are suffering from arthritis and its associated diseases. Next slide. And it wouldn't be possible to talk about PAFLA without acknowledging the space our mother organization, the African League Against Rheumatism, occupied. Since 1989, they have been the voice trying to champion for rheumatology in Africa. But at this meeting in Mauritius 2019, a decision was made to establish the pediatric arm, and that was the genesis of PAFLA. Next slide. Next slide, please. And at that conference, for the first time in the AFLA Congress, they had a pediatric, let's go back, please. Previous slide, please. Yeah, so at that conference, for the first time, they had a session on pediatrics. It had never happened before in the history of AFLA. And going from extreme left to right, we have Professor Chris Scott, who really has championed the cause of pediatric rheumatology in Africa. And then second is myself. Then at the center is Professor Helen Foster, who has championed the cause for pediatric rheumatology across Europe and has developed a global learning platform. Next is Kate Webb, who's leading the training in South Africa. At the extreme end is Professor Ross Petty, who we say is the founding father of rheumatology and actually authored the textbook that we use in training. And I want to say at this session, all we did was to set up a WhatsApp group, and it had about 20 people. And that's how we started mobilizing people towards our agenda. Next slide. And again, remember I said knowing the context where we are in, right? A lot of attention has been on infectious diseases, but we are saying we can't leave out non-communicable diseases, and we still need to prioritize them because of the burden that it poses on the health ecosystem. All right. And for us, the COVID was a blessing in disguise because then it made us realize how we can tap onto virtual platforms and mobilize people towards a common vision and a common goal. As I said, we just started PAFLA with a WhatsApp group of 20 people. Next slide. And cognizant of the fact that Africa is rising, right, as highlighted by The Economist, that is one of the world's fastest growing continents. Next slide. We knew that it was important that we occupy our space to be able to advocate for these children. And when you're trying to bring systems change, it's important to develop a sense of urgency. And that's the picture that I was trying to depict previously of the gentleman sprinting, that we don't have time to waste. We need to move and move quickly. But we know even as we are trying to advocate, we have to be aware of the pillars of a strong health system, right? Data, diagnostics, proper clinical care, having information systems that can support you in your agenda, and not forgetting the importance of the health workforce. Next slide. And so, like I said, COVID was a blessing in disguise because we were a group of about 20 people, and we started having virtual meetings, trying to decide how are we going to move forward and recruit people. So we continued recruiting more people as we are trying to forge ahead with our strategic plan and vision and mission for the continent. Next slide. Right, so that's a group of us. We have my colleagues from Nigeria, Tunisia, Sudan, Rwanda, myself in Kenya, all coming together trying to develop a strategic plan for PAFLA to guide us in our way forward in advocacy for the continent. Next slide. And those several virtual meetings resulted in our strategic plan. Next slide, which has got several pillars, including research, economic sustainability, optimum clinical care, not forgetting that we have core values that act as the North Star that guide every action that we do, right? We strive for commitment, honesty, inclusivity, accountability, innovation, among others. And this now highlights our strategic pillars. So all the activities we do are aligned with these various strategic pillars as displayed, right? International collaboration is key. Economic sustainability is key. We need resources. Having systems in place is important to ensure transparency, and that's essence of institutional framework. And so in advocacy, what have we been able to achieve so far? Next slide. Next slide, please. So we've had virtual celebrations. We have a patient rubric on our website. We have a social media presence talking about the issue of arthritis in children in Africa. Next slide, please. Yeah, and we've got patient information in various languages, English, Portuguese, and Arabic, and French, because those are the languages spoken in most of the countries in Africa. Next slide. And we're also very happy about the newsletter which we recently launched in our Congress in May this year, that is showcasing the story of various African countries in their quest to conquer the burden of childhood arthritis and other rheumatic diseases. Next slide. When it comes to membership, remember we said we started with a WhatsApp group of only 20 people, but you can see all those countries in blue. We have members there, and now our membership is around 800 members across the entire region as highlighted. And education, one of the things we've been doing are monthly webinars, and it has been one of our greatest successes for the last 3 years, where we've had over 3,400 participants, and we collaborate with other organizations across the globe in educating our members, such as the Swiss-based JIR Winter School, and also our congresses are often very well attended. Next slide. Institutional framework. This is something I'm very passionate about, developing systems that ensure accountability and transparency. This is important because it's the engine that drives all the activities. So we have 2 full-time staff and accountants and lawyers available as need arises. We are keen on improvement of our staff. We have policy documents that govern how we conduct our business as highlighted. Next slide. Research, an area I'm also very passionate about. Next slide. So we were able to work together and just showcase the state of pediatric rheumatology in this particular publication with representatives from all the regions of Africa. Next slide. And when we did this paper, what we found, we only had 10 countries in the continent that have pediatric rheumatologists and ultimately pediatric rheumatology centers. And hence we have our work cut out for us to ensure all the 54 countries are not left behind. Next slide. We've also worked together with the adult rheumatologists when we're looking at some of the management of rheumatic diseases during the COVID pandemic. Next slide. Next slide, please. All right, again, I was looking at the practice of rheumatology during the COVID pandemic. Right, next slide. Another publication we recently did was looking at the review of African literature in management of one of the vasculitis diseases known as Kawasaki. And we found that the management is really dependent on the resources that people have. Another very exciting publication coming soon, we're going to be releasing it soon, about looking at the clinical profile of juvenile dermatomyositis, one of the muscle diseases. You see, all this is effort from collaboration. Right? We've had 3 congresses so far, and we've had over 270 abstracts published, and we were fortunate to get a Red Cup platform, and we will be releasing soon our publication on juvenile idiopathic arthritis across Africa. What is the manifestation, clinical features of this entity? So one of our greatest highlights. Next slide. As I wrap up now, in the interest of time, yeah. It's important to give people the power of voice. Let's go back, please. I strongly believe in that, yeah. Honor the voice of people, honor their experiences. And it is for this reason we have partnered with specific journals, such as the Pediatric Rheumatology Journal, displayed so far, where we have called for people to share their lessons in their practice, in their context, right? And this collection has about 15 accepted publications so far from Africa. The next collection that we are working on, next slide please, is with the Journal of Frontiers in Pediatrics, where we are trying to emphasize how are people promoting patient-centered care for pediatric rheumatology across Africa. So if you're interested, the deadline is until August 30th. Please feel free to submit. Next slide. Next slide, please. Yeah. Maya Angelou said, if you're going to leave a legacy, make a mark on the world that cannot be erased. Next slide. And that brings me to my last and 6th lesson about handing over the baton. This is really important. This is really the foundation of mentorship, so that other people can continue the journey. And we cannot do this alone. These are some of the partners we have worked with in PAFLA. And it has been a joy and humbling experience to work with all these people. Next slide. And even as we work with all these various partners, we are very cognizant of the need of handing over this vision and this mission. And so for us, we are very passionate about the patient and other rheumatology collaborations so that other stakeholders can see where we are going and work with us. We are looking to double our membership because it's important to have people to continue with this mission. We are looking at having in-depth one-on-one courses in various regions in Africa and even launching a fellowship program so that we can train people in the skill set necessary to carry forward the mission. We are looking to optimize our communication strategy and digital footprint and ultimately increase our resources to drive forward this mission. Next slide. Next slide, please. Yeah. At Hope Arthritis, there are various other programs we are having. We have a masterclass to help health workers know how to diagnose purely from history and examination. In the month of September, we're going to be having a masterclass for guardians and health workers. In July, we're having a pediatric rheumatology bootcamp. Very fascinating for a whole month, training people on how to diagnose and give them the tools for diagnosis and follow-up and treatment. We offer a virtual support group, and that's the website and an email if you have any queries. Next slide. I've talked about fellowship training because it's critical that we develop the workforce that will continue with this vision and mission for Africa. Next slide. One of the people I really admire the most, our Nobel Peace Prize winner, commended for her advocacy in peace because she believed a lot of the wars we see in our world today are because of competition for natural resources. So if we can preserve natural resources, then we can help mitigate some of the conflict and war. And she said, in the course of history, there comes a time when humanity is called to shift to a new level of consciousness, to reach a higher moral ground, a time when we have to shed our fear and give hope to each other. And that time is now. And Professor Camilla talked about it. Be brave, be courageous in your pursuit for your advocacy agenda. I already shared the outcome of this wonderful girl. We were able to save her from having an amputation, and she now goes to school and leads a normal, healthy life. Next slide. I think I'm towards the end. Next slide. And I conclude by a quote from Kofi Annan that knowledge is power and information is liberating. And education is the premise of progress in every society and in every family. I believe that's the end of my presentation, and I look forward to answering any questions. And a big gratitude to patients who inspire us to improve and be better healthcare providers. And of course, I wouldn't be here if it was not for my mentors and my mentees, the younger colleagues I teach. They also teach me a lot, and the teachers in my professional journey. Thank you so much.
Thank you very much, Angela. That was absolutely fantastic. We're going to move on to some question time now. So, Angela, we'll give you a rest for just a couple of minutes, and I'll ask Dr. Kingdon a couple of the first questions. Are you there still, Dr. Kingdon?
Yes, I am. Yep.
Hello. Great. So just to allow some people to type in questions to Dr. McGowan, we'll just start with you if that's okay. So one of our questions was, could you elaborate a bit further about what kindness means in the context of leadership? So I guess, what does it actually look like on a day-to-day kind of basis?
Yes, happy to do that. I think I noticed that question, and I guess I just want to be clear, because if any of you are interested in reading further about this, I think it's important to make a distinction between compassionate leadership and intelligent kindness. And the reason I'm making that point is actually there's a big evidence base and literature out there about both these. And I think they're a bit like two circles in a Venn diagram. There's overlap, but technically they are slightly different. And the researchers have looked at these topics in slightly different ways. I think I don't want to be sloppy about just throwing the terminology around without being clear that actually intelligent kindness is something different to compassionate leadership. So kindness actually comes from an old Anglo-Saxon word, which is where we get the word kin from. And kin, as you know, means family. So in the African equivalent is Ubuntu. So actually we've got there is a language now that actually nations across the planet have found, which is all around that kind of connection between human beings and this concept of kind of shared humanity. Ubuntu means I am because we are. So it's this idea that we have this shared human experience. And I think the importance of kindness, particularly if you read the literature around intelligent kindness, is that if you tap into that shared humanity, they talk about this wonderful concept of listening with fascination, which I just love. So when you listen with fascination to somebody, you're giving them your undivided attention, and you're thinking about what they're saying. You're not distracted by your phone. You're not worrying about the fact that you're going to be late to pick up your kids, etc., etc. You're listening. You're giving them 100%. And if you think how often does that actually happen in our busy working lives? And so I think that concept, which is an intelligent kindness concept, can be applied to compassionate leadership. And I think is one of the kind of amazing crossovers between the two. So I think there are lots of principles from kindness that we can use in compassionate leadership that strengthen the way in which we behave and how we interact with each other. If anyone's interested in intelligent kindness, I would recommend Penny Campling, Campling. She's written beautifully about it, and there's this big evidence base now for improved patient outcomes. Some really fascinating improved wound healing rates, speeding up discharge from hospital when staff are enabled to behave kindly and really be attuned to their patients' needs. It's fascinating, really, really interesting.
That was a very thoughtful answer, Camilla. Thank you for that. Another question for you while Angela is resting her voice. A question actually from Sanjay Suri, who's going to be one of our speakers tomorrow. He wanted to dig a little bit deeper into the data that you showed on your talk, and was asking, apart from poverty, what are the other reasons that you think we have these poor child health outcomes in the UK?
It's a great question, Sanjay. I mean, I think a lot of this, and I think this is probably true around the world, is the fact that women and children are typically not prioritised to the same degree that the adult population is, and in the UK particularly, because we've got this enormously growing elderly population. Of course, that needs a lot of thought and care and attention, but I think it's been at the expense of children, and that's not just in healthcare. I think it's actually in society. And so some of the decisions that are made around how funding is prioritized is often, I think the assumption often is, children are healthy, and we don't have to kind of overly worry about them. But the truth is that we know that children's health needs are increasing dramatically, and I think have been accelerated by the impact of the pandemic and other sort of societal changes, the influence of social media and so on. But particularly on the UK data, I think poverty actually is the number 1, 2, and 3 underlying issue that's leading to our terrible health outcomes, particularly in the north of England and in other deprived communities. And then we also know that another big significant contributor to the rising child death rate is the rise in congenital anomalies, are largely related to first cousin relationships and consanguinity, and lots of kind of cultural issues there that we've not been good at grasping. A lot of kind of culturally sensitive conversations that need to happen that perhaps we've just not paid enough attention to. So if you look at the data, the congenital anomalies are significantly contributing to our rising child death rates.
Thank you very much. We'll move on to a couple of questions for Dr. McGowan now. So one of the questions is, what would your advice be for young leaders coming through with the current restraints that they face?
I think one of the key things, and it does take time to be clear on it and decide it, is to ask yourself, what is your purpose in pursuing a particular leadership agenda or advocacy agenda, right? It's really important to be clear on that. And most of the time, your purpose is linked to trying to find a solution for people's problems, most of the time, right? So I think the first step is really ask yourself, what is my purpose? What is the solution I'm trying to find for the society I am in? And then the second thing, once you're clear on that purpose, then self-reflect, interrogate yourself, and see what are my strengths and weaknesses as pertains to achieving that mission or that agenda. Why that's important is because nobody is perfect, nobody has it all together. Your strengths, you should capitalize on them, and then the areas where you're weak, I would say get a personal board of directors, people who will guide you to conquer those weaknesses. Then once you have done that self leadership, because you cannot lead others if you cannot lead yourself. So once that is done, then now look for stakeholders within your ecosystem who share in that vision. And as Professor Camilla said, you can't do it alone, right? So you work together with them to achieve that agenda. I think those are the 3 points I would highlight for the younger upcoming leaders.
Some wonderful points, Angela. Thank you very much for that. Another question for you. There was a comment that red cap registries have been really great for other services as well. The question was around what ethics processes did you need to take to publish your data, or did you find any particular challenges in working with ethics in vulnerable communities, such as those in rural and remote areas or Indigenous peoples?
Yeah, that's a good question. So because we were looking to just describe what is the clinical presentation and outcomes of children with arthritis across the continent. So the first thing that we did was, of course, designing the protocol, and we opened it out to all our members, those who want to participate. It's important for people to join in freely. So once we were able to get the buy-in of all those who are interested, the first step was that they were to seek ethical approval from their home institutions. That was the first step, right? And before we went there, it was important to get their buy-in. Once they got approvals from their home institutions, they would submit that to the PAFLA Research Committee for the Research and Ethics Committee to verify the authenticity of those approvals. And then once they got that, then we gave them, as the PAFLA team, our approval to go ahead and input the data. And that's how we're able to get the approvals to publish the data. So it was 2 levels, from their home country and from PAFLA. What are the challenges we faced? As you can imagine, Africa is so heterogeneous, and every country, every region has their own unique rules that we need to comply with to be able to get approvals. So in some countries, it took like 2 weeks. Other countries, it took even 4 months. The key there is to be patient, understand the systems of the countries you're hoping to collaborate with, and having constant, regular engagement to brainstorm on the challenges and finding solutions. And that's how we were able to navigate some of those barriers.
Wonderful. Thank you for your insights on that. I think it is about time that we wrapped up this session. We have gone a little bit over time, but I would just like to acknowledge that we did have many questions we were unable to get to at this point, but hopefully we were able to stimulate some thought, and further discussions can be ongoing as we work together to change the face of paediatric leadership going forward. So I'd just like to take the opportunity to thank Dr. Kingdon and Dr. McGowan again for their very insightful talks. Lots of great points that I will be taking away, and I hope that this can be the start of an ongoing collaboration, as you've mentioned. So we will end this first session here. There will be a 45-minute break now, so everybody can go get a coffee or go get something to eat, use the bathroom, and we'll be back online in 45 minutes' time to commence the second session of the day with the theme of advocacy. So enjoy your break. Thank you again, Camilla and Angela, and I'll see you all online soon.
So welcome back, everybody. I hope you've had a good break. So for those of you that weren't on the first session, my name is Vicky Timmis. I'm a paediatrician from the UK, and my co-chair is Alicia Mitchell, a paediatrician from Australia. So this second session is going to look at advocacy, thinking about how this applies not only to the children that we see individually in front of us and their families, but also how that can apply to us for the development of health policy and our work with organisations, and how, as paediatricians, we can use advocacy to in the global fight for children's health and for children's rights. So it's my pleasure to introduce Professor Margie Danchin. She's a consultant paediatrician at the Royal Children's Hospital and a clinical scientist at the University of Melbourne, Australia, and the Murdoch Children's Research Institute. She's completed a clinical fellowship and PhD in Toronto, Canada, and she currently holds the Melbourne Children's Clinician Scientist Fellowship. She's a group leader of the Vaccine Uptake Group for Murdoch Children's Research Institute, and her research focuses on vaccine confidence and uptake. So it's a pleasure to have you with us. Thank you very much for joining with us. I'm sorry for the technological difficulties. Smoothly now.
Good morning, wherever you are, everyone. It's a pleasure to be with you. I'm joining you from Brisbane, actually, for our National Immunisation Conference here. So apologies for the small technical glitches, but it really is a pleasure to be with you, and thank you for the very generous introduction. As you heard, I am a general paediatrician and a vaccinologist, and I've been working in the field of vaccine research for about 15 years or so. But what I'd really like to share with you is my journey, I suppose, particularly over the last 4 years or so, in terms of really strong advocacy around global child health, paediatric child health, which really was amplified, I suppose, as it was for many of us through the pandemic. So I'm going to talk to you a little bit about my space, which is vaccination and vaccinology and improving vaccine uptake in children. And through that lens, I suppose, how I've really been advocating for child health in Australia and globally. So when I actually finished my paediatric training, I did a PhD in vaccine clinical trials, and I worked in New Zealand, and then these are some images from Indonesia, where I worked on a oral rotavirus vaccine clinical trial with Professor Julie Bynes, and we were looking at a neonatal rotavirus vaccine dose, and that was what I was really passionate about at that point, and looking at the impact of maternal antibodies on why these vaccines didn't work as well in developing countries. But next slide. I became increasingly concerned about misinformation around vaccines. Sorry, next slide. Yeah. Increasingly concerned about misinformation around vaccines and the anti-vaccination movement. And you may or may not recall this documentary that was released in 2013 called Jabbed, Love, Fear and Vaccines by Sonia Pemberton in Australia. And it really looked at the anti-vaccination movement and the impact of fear and adverse events around vaccines, and a lot of misinformation and conspiracy theories. And it just made me acutely aware of the fact that, immunisation is the cornerstone, really, in some ways, certainly in the low and middle income country settings, for child health, and has been one of the greatest impacts in terms of public health globally since they were introduced, and we've really celebrated that this year. But that if children weren't receiving vaccines, and adults, that really we were not using these resources appropriately, and just the impact of this misinformation really gripped me around how we needed to use this resource more effectively. Next slide. And of course, these vaccine preventable diseases then, this was around 2015 or so when I had this realisation, but here we sit in 2024, and sadly the impact of the COVID pandemic on routine childhood immunisation, as I'll talk about in a minute, has been profound. And we're seeing measles returning in many corners of the globe. That's the image there on the right, as well as meningococcal meningitis, pneumococcal meningitis. And then on the top left there, you can see an infant who has whooping cough. And these are real impacts still for many children and families worldwide. Next. And so in 2019, I became aware that vaccine hesitancy was actually identified by the World Health Organization as one of the top 10 threats to global health. And of course, this was before COVID. You can see some of the other impacts there, really important around weak primary healthcare, which is still an issue, dengue, HIV, lots of non-communicable diseases, which I don't want to play down, particularly the impact for adolescents and mental health and obesity and malnutrition and so on. But vaccine hesitancy and reluctance to accept and receive vaccines was really identified then as a leading global health threat. Next slide. And so here we are. These are some data from last year from the UNICEF State of the World's Children report. And it's quite astounding, actually, the impact of the COVID pandemic. We now have the worst coverage rates globally for children in 15 years, and 1 in 5 children globally have received absolutely no vaccines at all. And you can see there through the COVID pandemic from 2019 to 2021, at least 67 million children were under-vaccinated, and 48 million of those children were 0 dose or received no vaccines. Next slide. And of course, in Australia, where I am, this is also impacting high income countries as it is in the US and the UK and parts of Europe. Coverage has declined here for all 3 age groups. We measure coverage here at 12 months, 2 years and 5 years. And you can see the decline there in all age groups, and particularly for First Nations children, whom have had the largest drop. And there's already a widened gap there for their health outcomes, but there's been a drop in at least 3% for them. So this is really concerning data for kids globally. So through COVID and now, I'm still determining how best we can advocate for children. So what I'm going to really share with you now is what can I do as a paediatrician and a child health and vaccinology researcher. The first is to really work internationally with leading non-government organisations. And I've been working with the World Health Organization and UNICEF for over 10 years now. And this is really an image in 2019 when I went to Geneva and was at WHO and was starting to work with their demand team on issues around vaccine hesitancy and particularly maternal immunisation and influenza vaccine uptake in pregnancy. And this was pre-COVID. Next slide. And then, of course, the pandemic hit, and I was seconded to the Victorian government in 2021 when our COVID vaccine rollout started, like it did globally. Incredible achievement that we had the COVID vaccines within 9 to 12 months, when it normally takes at least 15 years or 10 to 15 years to develop new vaccines. And these images are actually from the celebration that we held in Victoria 18 months after the COVID rollout in June 2022, where we celebrated the incredible achievements, mainly from community-led strategies and partnerships on the ground in our public health units and local public health districts, everyone pulling together to try and engage with communities and cut through misinformation and achieve high coverage with outreach services, pop-up clinics, and many different strategies with different cultural groups. And you can see here, that was our Chief Health Officer in Victoria at the time, Professor Brett Sutton on the far right there in the mask. And they were the sort of leading public health advocates in Victoria at the time. But in that celebration on that day, when we really, had achieved over 95% coverage for primary, so 2 doses for adults in the state, we were celebrating with the Somali community and all the different cultural groups on what had worked, and what an incredible achievement it was for government, academia, and the public health system to work so effectively together. Next slide. But at the same time, when I was seconded to government, I was also part of another national group that we have here in Australia. I was chair of COSI, or the Collaboration on Social Science and Immunisation, and we developed a white paper or document for government on how best to achieve high coverage in the community, right down from sort of high-risk adults to children. And we focused on the key access and acceptance barriers, and you can see there around policy and health worker support and access strategies, but then really importantly, those broad campaigns in the community, strong community engagement, and that interpersonal communication, one-on-one support for providers to have those really important risk-benefit conversations with adults and children. Next slide. And as part of COSI, we did some really important work publishing in the MJA again, which was important for the government to use to inform policy around, one, that risk-benefit communication with the public and patients, and that was in our document there, or the paper around communicating with patients and the public about COVID vaccine safety. And then secondly, around the broad use of vaccine mandates, which I'm sure all of you recall in your different settings, just how broadly these were introduced, not only for healthcare workers and in health settings, but across the whole health workforce, to the point that even pregnant women, if they were in a working role, were mandated to receive a vaccine in pregnancy without the same vaccine safety data that we would apply to other population groups. And of course, we worked very closely with government to try and achieve high vaccine uptake for primary school children. And then another really important strategy, as I said, apart from working with government and informing policy, was community engagement. And we've worked in Australia, in Victoria and nationally with different communities, and now we've expanded our what we call Vaccine Champions program to the Asia Pacific region, to Fiji, Tonga and Vietnam. And we've trained healthcare workers and diverse community vaccine champions. So that includes community leaders, religious leaders, sporting stars, people from disability organisations and women's organisations, and trained them around vaccine knowledge. So it's not just a matter of having a Band-Aid or a sticker or a badge saying you're a vaccine champion, but actually training these people with 2 days of face-to-face training around vaccine knowledge and education, as well as vaccine communication skills to go into their communities and speak with parents and the elderly about why they should accept vaccines, because people trust those people from their own communities. And so these programs have now been accepted and funded by DFAT and the Commonwealth Government in our region in 6 countries. And I just highlight this as a really effective strategy around advocating for child health at a grassroots level to really engage with communities and have community-led strategies. Next slide. And you can see here, these are some images from our work in the Philippines, speaking with different communities, mothers, about why they should give their children routine EPI vaccines, working with rural public health units, districts, municipalities, And it's incredible the impact that these programs have had already on parental knowledge, healthcare worker knowledge, self-efficacy around vaccine communication, and most importantly, vaccine uptake. Next slide. But of course, we all are familiar with sort of broader campaigns to inform or educate the public. And here are just some examples during our COVID rollout in Australia between 2021 and 2022 was the Australian Academy of Science, different videos and webinars, resources, specific resources tailored to our First Nations or Indigenous communities, but also some fantastic examples of really powerful advertising campaigns. You can see down there the one from New Zealand called Do It For Each Other, where it was so clear that it was beyond the personal benefit around vaccination, and it was around protecting our families and communities and getting back to the way of life that we all knew. And that they were really powerful, emotional, broad campaigns that motivated the public to be vaccinated. Next slide. And there were other examples that were quite effective through that time, and I think can continue to be moving forward in terms of advocacy. Down the bottom there, you can see Professor Sharon Lewin, who's well known to many, who's the director of the Doherty Institute here in Victoria, and myself and Professor Terry Nolan, where we were at the Melbourne Convention Centre in Victoria, and we had a couple of hundred people in the room and 2,000 or 3,000 people online, and we just took questions from the public for 2 or 3 hours and tried to really cut through what people wanted to understand and know. And the top example were about 40 videos that I recorded around common questions around COVID vaccines for parents, which we had translated into different languages. Again, really advocating for why parents should vaccinate their children, common questions around safety and effectiveness. The middle was a podcast that we ran through the Royal Children's Hospital in Melbourne with colleagues Anthea Rhodes and Lexi Frydenberg, again, talking about common child health issues. We covered lots of issues in that podcast, from diabetes, constipation, sleep issues, respiratory issues, and vaccines as well. And then that last example there on the bottom right are some decision aids that we published through the National Centre, again, to help people make decisions. And then this last example is really around interpersonal communication. And this is a website that we developed over the last 5 to 8 years called Sharing Knowledge About Immunisation, where we've got resources from maternal immunisation, childhood, into primary school and secondary school immunisation, and for adults. And it's really, again, providing resources for the community, for parents, and also for providers on how to have effective conversations. And this has been adopted by the Commonwealth and is now available broadly in all primary care practices across Australia. So another really powerful way to advocate with strong and reliable health information. And these were some of the decision support tools that we developed around COVID vaccines for children when parents were very unsure whether they should vaccinate their kids. Next slide. So I guess I just used that as an example. That is the space that my research predominates in Australia, in the Asia Pacific region, around using such a powerful public health tool as vaccines, but very broadly for child health research, engaging through policy, through government, through community engagement, interpersonal communication, broad campaigns in the media. But most importantly, I think we have a responsibility as paediatricians and leaders in this sphere to be positive, what is called, I love this phrase around having contagious positive energy, inspiring our teams and our organisations and the community about looking after each other and building each other up and listening. And it's not about the leadership of one, it's about promoting the leadership of all and moving together. And I've tried to do this in another one of my roles, which is as the Director of Clinician Scientist Pathways in the Melbourne Medical School. And I started a group called Women Clinicians in Academic Leadership. It was really for women clinician scientists at any stage of their career, from junior medical students to junior doctors all the way up to senior professors, about how women can lead, combine clinical medicine and research and support each other. And really, how do we balance all of the competing demands, which include family, clinical work, research? Where do we prioritise our time, and how best, in my sphere, do we advocate for children and support children, and what is the best way to do that? And this was a symposium that we held in March last year, which was a day which had a fantastic array of panel discussions, workshops around how to do that a work-life balance, juggle, and how to have effective conversations and to communicate in all spheres of our work. Next slide. And as I said, in my other role as the Director of Clinician Scientist Pathways, I've been developing in the Melbourne Medical School a pathway for the MD PhD, so for medical students to do a PhD during their clinical training, or for vocational clinicians, so during their specialty training, to do a PhD, which is not easy. How do we create these structured, supported pathways where we feel that we are being mentored, supported, we're paid adequately to combine research and clinical work? And I can tell you, I did my PhD in 2000 and it was not easy. I've had 4 kids since then, and I have lots of war stories, and I guess it's become a lifelong passion of mine to support other women undertaking this path, and hopefully having a more sort of positive experience right from the get-go, and just feeling that this is a really important way to influence our field and to support children is to have the best evidence, and the best evidence is through combining clinical work and research and changing clinical pathways and care. But it's not easy, so hence these pathways that I've been working on. And so I developed the Research Training Academy in the Melbourne Medical School, where I'm trying to bring together these different cohorts of medical students doing a PhD, specialty trainees doing a PhD, and postdocs to share their experiences, mentor and support each other, share how they are juggling the elusive work-life balance. And really, I think ultimately I've come to the conclusion that work-life balance doesn't really exist. You just decide at different times of your career what goes into that box, whether it's more clinical work, more research, more family, or nothing at all for a period of time. Like, I didn't do any work for 18 months after my 3rd child. So I think we all have that responsibility to juggle and to try and determine what's best for us and our families. And in my opinion, family always comes first. Next slide. So I'm going to finish there and just say that I feel really passionate about my career, and I feel incredibly blessed and privileged to have had this path. But I have always been supported by a village and by my colleagues, and I'm buoyed by them and inspired by them. And I know that I'm always learning. You never reach the end, and I think that's really good to know. There is no end, and I encourage my teenage children who are now starting out their university lives. It's a lifelong journey. But I think for us, in terms of advocating for children and families as a paediatrician, it's about looking for all of these avenues where we can have impact and make change, and to support our colleagues and the families that we work with. So my last slide is just a very broad acknowledgement slide, because I can assure you I work with a very large village. Next slide. In my own team in the Murdoch Children's Research Institute, and I'm incredibly privileged to work in the Asia Pacific region with UNICEF, WHO, all those academic organisations, as well as the Australian Government and the Australian Regional Immunisation Alliance. And the very last slide does list by name my dear colleagues, whom I would like to sincerely thank for many years of wonderful collaboration, support and friendship. So I'll stop there. Thanks very much.
Wonderful talk, Margie. Thank you very much for your time, and I'm glad we were able to work out the technical issues to get you online. Some amazing things that you've been able to be a part of, and some really important initiatives that you've been spearheading that I think many of us hope will be copied across other universities and across the world, because I think these are amazing initiatives, and it's hard being a woman in medicine, and it's hard trying to balance the demands of research and teaching and clinical work and family. And I think it's a very important point that you make, that you can't always have it all just at one time, maybe across your career, but not all at one time. So I think that's a really important point. I will hope that you could stay online until after Maria's
talk. Yes, I'm happy to be here.
Okay, wonderful. So if anybody has any questions, Margie, please put them in the Q&A chat function, and we will do questions after Maria's talk. So on that note, I would love to take the opportunity to introduce Dr. Maria del Carmen Cadevilla. She is an amazing pediatrician who graduated from the Cayetano Heredia University in Lima, Peru, and she specializes in adolescent health and development. She has a master's degree in government and health management, and she completed a doctorate in public health. She completed postgraduate studies at the National Center for Higher Studies in Lima, Harvard University, the Pan American Health Organization, and the World Health Organization, with a focus on adolescent health and development. She was a regional advisor on adolescent health for PAHO in Washington, D.C., and was a vice minister of public health at MINSA, Peru. She is the executive secretary of the Andean Health Organization, and she has held a range of different management positions in the pediatric scientific organizations at national, Latin American, and global levels. She is a current member of the Standing Committee of the International Pediatric Association and is a member of the Scientific Committee for the 2025 IPA World Congress in Mexico. She has received major awards for her academic leadership and the development of national and international support for adolescent health, as well as the highest distinction in public health in Peru. So I'll now hand over to Maria, and she will give us some amazing insights, I'm sure.
Well, thank you. Thank you for the invitation. I will say thank you for all, but especially for Amy Gray of the Royal Children's Hospital. She is my colleague, and we work together in the Standing Committee of the International Pediatric Association, and she told me about the possibility to be part of this webinar. So thank you so much. I will talk about advocacy for children and adolescents' rights. The next, please. And the next slide, please. And when we talk about children's politics and policies, you know, in Spanish, politics and policies are the same. We use only one word. But I know that in English we use two words and they have two different meanings. But advocacy in children's politics and policies requires a diverse set of skills to effectively promote and safeguard the rights and interests of children. Next, I will share with you some key skills needed. Next, please. The first of all is the empowerment and the participation of children and adolescents. We have to be clear that children and adolescents know what are their expectations, their desires, and we as adults can share with them their necessities. But if we want them to be empowered and have an active participation, we need to teach, increasing children and adolescents' knowledge about health areas and their rights. And now we are including climate change, mental health, and others. The next step is to promote their participation, inviting them to policy decision spaces at the local, national, regional, and global level. And the third one, making the participation real with empathy and respect. They know what they need and want. Next, please. The second is the communication skills. First of all, the oral communication. Clearly articulate ideas and arguments in meetings and public speaking events, in media engagements, and with children and adolescents, not just with their parents. We are talking about having communication skills to talk with children and adolescents also. Written communication, write compelling reports, policy briefs, articles, and social media content. And the most important, listening skills. Understand the needs and perspective of children and other stakeholders. We have to know what they are not saying. This one, the pediatric clinic knowledge. We have to have knowledge, and there must be an update in pediatric clinic. The medical advances, the policy changes, the technological updates, the patient care information. For example, this is a webinar that we had in 2022, and we're talking about the post-pandemia and the children care in the Andean community. You know, these webinars are every week, and can you don't go so rapidly, please? And one of the things, these webinars are translated to English also. The next one, please. The next one. The knowledge of child rights and policies. We have to know what the United Nations Convention on the Rights of the Child says, and what are the general observations. And we have to know the year in form of UNICEF about the infancy state. And we have to analyze this policies and propose improvements of new policies and benefit children. Here, we are talking with adolescents about sexual and reproductive rights in the World Youth Meeting that was held, I think it was 2 years ago. The next one, please. Research skill. Data collection and analysis. Gather and interpret data related to children's welfare, education, health, and other relevant areas. Evidence-based advocacy. Use research findings to support advocacy campaigns and policy proposals. But please make research with the adolescents, with the children. We had this evidence about podcasts as a prosumer tool for the childhood and adolescents, their rights. And they talked about auto-confirmation of knowledge and about technological appropriation. We have to ask them, and we have to have research, including them in our research. Next one. Networking and collaboration. We have to build partnerships, form alliances with NGOs, government agencies, community groups, and other stakeholders. And we have to work in collaboration, working effectively within coalitions. For example, we work with PAHO and we work with WHO. We work with the Alliance of Pediatrics of Latin America. We work with Rotary, because Rotary, one of their first aims is to end polio. We work with BID with projects, and we work with the International Pediatric Association and other associations as the International Association for Adolescent Health. Now I am part of the Latin American group in the Global Fund, and we work with UNICEF. It's very important to have a networking and collaboration. Next one, please. And the public relations and media skills. We have to have media engagement, but using traditional and social media to raise awareness and influence public opinion. Don't forget that many parts, for example, in the Andean region, many parts don't have internet. So we have to use the traditional medias. Campaign management, plan and execute advocacy campaigns. The strategic, and here, this is an example. We had a huge campaign voting for the children. And we have to have a strategic thinking and planning, goal setting, strategic development. For example, the International Pediatric Association has their strategic plan 2022 to 2027. Next one, please. And leadership. We have to inspire and lead, motivate and lead others in advocacy effects. If you are a leader, you have to address objectives. You have to solve problems. You have to recognize people, and you have to do feedback. And this is a very clear example of leadership. Here are the health professionals in one of the biggest congress in my country of adolescent health. In the red arrow is the Minister of Health. In the white arrow, it's me. The idea to be a leader is to serve, and to be a leader is to be part of all the movement. Cultural and gender competence, sensitivity to diversity, understand and respect cultural, social, and economic differences when advocating for children for diverse backgrounds. Next one, please. And negotiation and persuasion. Engage in discussions and negotiation with policymakers, stakeholders, and opponents. And persuasion. Convince stakeholders and decision makers to support child-friendly policies and initiatives. Next one. And we have to remember the soft skills. We talked about communication, but we have to have self-motivation, leadership, responsibility, teamwork, problem-solving, decisiveness, ability to work under pressure and time management, flexibility, it's very important, and negotiation and conflict resolution. Next, please. I will talk about my history. In the 60s, I was in the Boston Children's Hospital because I had 2 surgeries. And that was my professional decision. I was 8 years old, and I was the interpreter, the translator for the doctors of all the needs of the Latin American that were present there. And in those days, I decided to be a medical doctor. I think that I decided to be a pediatrician also. In the 70s, I was in the medical school, Universidad Peruana Cayetano Heredia, that has very academic excellence and that taught us to serve all the people, in special the vulnerable people. In the 80s, I made my pediatric training, also in the Universidad Peruana Cayetano Heredia, and I began to work in the largest orphanage in my country. I had 1,000 children and adolescents from 0 to 18 years in my church. Really, it was an opportunity to know that if we don't work in team, if there is no teamwork, and if we don't work with the other professionals, we can't do more. And I began my private practice in one of the most prestigious clinics in my country. In the 19th, I was the director in one of the regions of Peru. The Callao is one of the regions. And I went to the Ministry of Health and had different positions. Parallel to this, I made my master in government and health and health management, and I continue with my private practice. In the 2000s, I was a health promotion advisor in the Ministry of Health. I was the advisor of the First Lady of my country in health, in children's health. And I went to the Committee on the Rights of the Child in Geneva, in Switzerland, to present the third inform of my country. I made my doctorate, public health doctorate, and I continue with a private practice. In the 2010, I was advisor of adolescent health in the Pan American Organization in Washington, D.C. I was the vice minister in public health in Peru, and I was the Latin American vice president in the International Association for Adolescent Health. In these last years, I am the executive secretary Andean Health Organization. It may be down south for you, but I work with 6 ministers. I work with the ministers of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela. And my work is to contribute to the health and wellness of the 170 million of people that live in the Andean region. I am part of the standing committee, the International Pediatric Association. I am a special advisor in the International Association for Adolescent Health. I am part of the Social Pediatric Committee Association Latinoamericana, and I am the coordinator of adolescent chapter in la Sociedad Peruana de Pediatría. The next one, please. I want to thank my people, the people that work me, and we are completely, we know that Bolivia, Chile, Colombia, Ecuador, Peru, Venezuela, together we are stronger, and together we go further. Thank you, all of you. And the next one, please. And I will tell you what Latin American children and adolescents say. Nothing for me without me. We really believe that the participation, the active participation and the empowerment of our children and adolescents is very important when we talk of advocacy for policies and politics. Thank you.
Thank you very much indeed, Maria. That's a fascinating talk, and what an incredible career you've had, and so many tips for us to learn. So thank you very much for that. We're just going to move on to the question time now. To give you a break, Maria, we'll ask the questions to Professor Danchin first, if that's okay. So please feel free to put any questions that you have in the chat function. There is a little speech bubble with a question mark on the top right hand side in your screen, so you can type them in there. We'll go through as many as possible. I had a question to start with, if that's okay. You talked about engagement with government and the media and communities and things, and you've obviously been extremely successful in how you've done that. I was just wondering if for people who are starting out of this journey and are passionate about wanting to spread messages on child health and things, what advice would you give to those kind of at the start of their journey and their career in that aspect and developing a platform?
Yeah, thanks, Vicky. That's a great talk. I mean, a great question, sorry. I think the most important thing is to really get comfortable with working with the media and with distilling sometimes quite complex questions and problems into simple answers. And it's not easy to do. I actually had quite a lot of media training through the Royal Children's Hospital and through Murdoch Children's Institute where I worked, where I did a lot of sort of answering questions to camera, watching it back, seeing, being taught how to speak in sound bites for TV. I did a lot of media through the COVID pandemic, which I wasn't initially very comfortable with. And it was a huge absorption of my time, a time sump, I actually called it at one point. And I'm not sure, you don't get paid for it. I had media crews coming to my house, and they come and you're in the front garden because it was COVID, of course, and be an hour and a half of your time. But I learnt how to communicate effectively, what they were going to use. And I think as I got more and more confident with TV, radio, print media communication, I got more bold with my approaches to government. So I approached the Victorian government, the Commonwealth government. I started wanting to work with them, again, communicating very clearly sort of complex concepts into sort of more simple expressions. And I think it was really hard, but I think I got more confident with that. So, and then once you have a relationship with government, it's a bit like what we do in our professional work, in our clinical work, in our research. It's all about relationships. So relationships with state government, Commonwealth government, they need to trust you. They need to know that, you're going to be a good spokesperson for them. So it was that engagement. And then from that followed the engagement with the Academy of Science, and they asked me to be a spokesperson and record videos for them. So I think for people listening, I'm perhaps making this sound a little bit easier than it was. It wasn't easy. But I think if you really develop good, effective communication skills, and I don't think I really understood what they were until I started trying to get better at it, it opens a lot of doors. And I think you become a lot more powerful as an advocate, because people switch off pretty quickly. If you're not clear, you don't speak in very simple phrases, and the media can't use what you're saying, they just walk away from you. And it's the same with government. It's the same with our research. We've got to distill our messages down. So I would encourage anyone listening, if they're interested in advocacy, whether it's community engagement, government, policy, to do some media training, some science communication training, because you will never regret it. I mean, it even is helpful in talks like we're doing tonight, just how do you communicate? How do you grab people's attention? How do you tell stories? I'm still learning, but I think it is the cornerstone of advocacy, is being an effective communicator.
Can I say something?
Of course.
Okay. Yes, as Marjo says, it's not easy. It's difficult. It's not easy. But I think that we have to have very clear who are our public. Who are we talking to? It's not the same, the government. It's not the same, the community. It's not the same, the health professionals. There are different publics. So we have to be very clear who are they. Second, data. Data is for the brain. Data is for the brain. Storytelling is for the heart. Storytelling. You have to talk about story, some
People.
history, some story, some people, because the people engage with the people. So you can talk about, yes, the coverture is never 90%. We are not okay now, but you can say, well, we have this little girl of 4 years that thanks for their I know their parents, the professionals, the health professionals. He went and he got the vaccination, something like that. And she didn't have the disease, but it's a person, it's somebody with a face, no? So, data for the brain. storytelling for the heart.
Very true, Maria. And in fact, the media always look for stories. That's all they want is a
Yes,
story. That's
yes,
what people
yes.
remember.
And we need to know how to tell the stories, because that's also capacitation. It's not easy. We have to know what to say first, what to say after that, and it's a skill. It's a skill. Now it's a skill.
Yeah,
Yeah.
I totally agree.
So Maria, I think following on from that point, can you talk more about how you dealt with these public health issues in Latin America? Did you come up against some of the same issues that Margie has talked about with the COVID-19 pandemic and vaccine hesitancy?
Well, when I was in the pandemic, it was my first week as executive secretary of the Andean organism. And the first thing that I talked about was we have to survive, because we were just in a war. The pandemic for Peru was a war. And if you see the numbers, Peru was one of the countries with most mortality, okay? Because the vaccines didn't come immediately. We had that problem in our countries. The vaccines didn't come immediately. We had to wait for the vaccines. And that's an issue of public health. No, we have to be very clear that when we talk of vaccines, we have to say, okay, I am defended. If I have the vaccines, everybody has to have the vaccines. Why? Because everybody goes in flights. Everybody goes from here to here. Everybody is coming, the diseases are going from continent to continent. So everybody must have the vaccines. For example, I have been a week ago, I was in Singapore, and now I am in Peru. No, so there are many communication, and the communication is okay, but the idea is that everybody has the vaccines, for example. And so the first thing that it was we didn't have the vaccines immediately. Second, we don't have a very good health system. We don't have all the things that are in the developed countries, so it was not easy. No, but public health is synonymous of the health of everybody, not just of some groups. And is particularly difficult when you have a country when there are many kinds of nations. We have in Peru 51 nations. We have coast, highlands, and jungle. We are not equal, okay? And it's a very huge area. So I think that the best part of that was that many people work together. No, and when we are talking about many people, we're talking not just of the health professionals, but we are talking of the NGOs, the external cooperation, and all of this. My organization began a weekly webinar because there was so much fake information, so much information that was not the last one, it was not updated, that we thought that the people need to have the real information. You know that the pandemics was not easy. In the beginning, we didn't know many things, and in the weeks, we made it possible. And in all the countries, we have a region. I don't know how it's in Australia, but in all the countries, we have regional health no directors. I don't know how they say them. We have local directors and national directors. The level of national is the ministries. My organization works with the ministers, and we have more than 22 committees, 3 subcommittees, and many other groups of work that are with the representatives of the ministries of the 6 countries. So anything that we do, like a politics or policy, is in a consensus of the 6 countries. That it's not easy, huh? It's a little bit difficult. It's not easy. It's very, that's all I can say. Thank you.
Thank you very much. It's quite incredible to think about how so much was done in such a short space of time, isn't it? So we maybe have time for one more quick question to squeeze in. Someone's asked a question for Margie, which is again related to COVID-19. How did you bridge the workforce gap to deliver the vaccination services?
Yeah, that was really difficult. And I think we were able to mobilise a lot of nurse immunisers in the community, and there were a lot of outreach services. So rather than, getting people to come into clinics and so on, there were a lot of outreach services going into communities. But it was a challenge. There just weren't enough immunisers. And of course, in our state, we also had a lot of tailored pathways for children who had severe needle phobia or had autism and developmental disabilities. So we had to have low sensory environments in our vaccination hubs. So there were a lot of tailored vaccination pathways that were developed. But I did notice one person asked here about how to approach vaccine hesitancy in the clinic, and I wondered whether you wanted me to mention that briefly.
Yes, of course. Yeah, thank you.
Yeah. So I think that's a really great question, and that is integral to our vaccine champions training, or those vaccine communication skills. And to be honest, I've been working on this for the last 15 or 20 years. I work in a weekly immunisation clinic and speak with vaccine hesitant parents. And I would say the first thing is really understanding where that person sits on the vaccine hesitancy spectrum, whether they're a refuser, whether they're really conflicted fence sitter, whether they're fully accepting, but just have a couple of questions, and really taking the opportunity to hear where they are, their top 3 concerns, let them sort of put their shackles down and express what they're really worried about with us jumping in. And then I use a lot of motivational interviewing techniques to reflect back and summarize, acknowledge their concerns, ask them if I can share what I know, establish my credibility, and then share trustworthy information. And it's incredibly sort of rewarding how, when you let somebody know you're not in for a fight and you're really ready to listen and hear them and try and meet them where their needs are and to answer their questions, just how rewarding it is for those people who are more sort of on the fence to be able to answer their questions and concerns. And sometimes answering the questions for one child means that, all the other kids in the family are vaccinated as well. But the true vaccine refusers are really, really hard, especially if they have entrenched trust issues, conspiracy theories around government and other institutions. That's a much harder, I won't go into that. That's a much harder conversation, but I can certainly share with you later, if people are interested, resources. That website I shared around Sky, sharing knowledge around immunisation, we have whole videos and fact sheets for providers on how to have those conversations. So there's a provider portal and a public-facing portal. And so we're really trying to give providers who are already accomplished communicators just better skills to have these difficult conversations, which we all know can be really tricky.
Absolutely. I'm sure a lot of people would really value you sharing any resources or other links that you have. And I know that Sue Wolfenden, who is going to be speaking on day 3 of our conference, was asking for some of the resources for your clinician researcher initiatives that you've started. So I know there's a lot of people that are... Okay. Yeah, absolutely. Okay, well, I think we will have to wrap things up there. Thank you so much to Professor Danchin and Dr. Del Carmen Kelly Davila for your time tonight, or this morning, wherever you may be in the world. We really have appreciated all your insights and knowledge, and experiences that you've shared. I think all of us can take those on board, learn from them, and we can continue to collaborate together to improve the leadership in the paediatric community. While we're here, I hope you can share my screen. I was just going to use this opportunity to spruik the IPA Congress that's happening in 2025 in Mexico. We are hoping that at that Congress we can continue to build on some of the ideas that come out of the 3 days of virtual conference that we have this year, and we're hoping to continue our theme of reimagining leadership in some symposiums in that Congress, and to continue to work together to hopefully develop some strong initiatives out of this work. So
Alicia, can I quickly mention that Dr. Naveen Thacker, who's obviously the president of IPA, we have developed an IPA vaccine trust course that's available online that we've worked on over the last 5 years or so, which you can do, and it's been done by hundreds of paediatricians globally. I don't know if any of your attendees might have done that course, but it has a lot of what I'm talking about. I did the interpersonal communication module for that course around vaccine hesitancy, but it's a fantastic IPA initiative, the Vaccine Trust course.
It sounds like an incredible resource for all of us, and I'm sure that lots of people will be looking for resources exactly like that. So thank you. Everybody go and do the course, please. Great. So these are the details for the Congress next year, if you want to get involved. And we will finish this session off here. Thank you all for attending. We have really appreciated the questions and the engagement. And day 2 will be on Wednesday, same time, same place. You should have the link, and if you haven't, you can scan that QR code, go to the IPALA site, and look for the Leadership Virtual Conference, and you can sign up for day 2 and day 3 there. Thank you again, Margie and Maria, and I hope that you all have a great day.
Bye, everyone. Thank you.
Bye.